Hi, I'm Kathy Rich, the producer and editor of Health Focus with Dr. Scott. Today, we're filming a very special episode with the Fairfield Sassoon Rotary Club. Welcome, Dr. Scott.
Well, it's really a pleasure to be with all of you at this combined meeting of the Rotary Club and also filming a live episode of Health Focus with Dr. Scott. And I really want to express my appreciation to Kathy Rich, who's been a fantastic friend and producer as we worked on the show for, it's getting close to 4 years, I believe. And when we started shooting the show, we actually were limited to primarily Vallejo, and then we expanded to Fairfield and Davis, and we've actually aired in Berkeley. And even though we film these shows typically once a month, it's been a challenge during the pandemic. So partnering with the Rotary Club is really a treat. And I thought what we would focus on today are the top 10 medical innovations that really are here for us as we see the beginning of 2021. And I think there's a tendency for us to just focus only on the pandemic. And I think we have to see beyond the pandemic and realize that there are other medical conditions that are worth considering. Nonetheless, I did add a brief set of comments about the pandemic at the end of this presentation. You might ask, where did I get these top 10 stories or top 10 innovations for 2021 as 2021 dawns? And I relied heavily on the Cleveland Clinic, which publishes a list of the top 10 medical innovations for every new year. And in fact, I also relied on my own thoughts in interpreting these innovations to some extent. And I hope that you'll find it useful. And I hope that we can instill a sense of hope and optimism because let's face it, 2020 has been something of a downer of a year. The nation has seen so many cases of this terrible condition associated with COVID-19 in our local community. We've had some people who've done a good job, I think, in trying to battle it. I'm thinking, for example, of Bella Matias, our health officer, who has been a friend of our show and has told us some of the information relative to the pandemic. But let's expand beyond that and talk about some other issues. So here are 10 new innovations that represent major medical breakthroughs as 2021 dawns. The first is gene therapy for hemoglobinopathies. Now, a hemoglobinopathy is a disease involving the hemoglobin molecule. The hemoglobin molecule really ferries oxygen to tissue. So the hemoglobin is in the red blood cells. It picks up oxygen in the lungs. It goes back to the heart. The heart pumps the blood through the body and into the capillaries where the oxygen is released to tissues. If you don't have oxygen, the tissues cannot function, the muscles cannot contract, and really the situation can be, in fact, incompatible with life. Now, against that backdrop, sickle cell disease afflicts 1 out of every 365 African Americans, and it can occur either as the full disease or as sickle cell trait, depending on whether both alleles genetically are involved. The result is chronic pain, tissue damage, episodes of flares of this condition, and it can cause premature death because individuals with sickle cell have damage to organs which don't receive enough oxygen, and they're vulnerable to infection and other problems like that. One of the new therapies that we've seen develop is the possibility of finding genes that repair this problem with the hemoglobin molecule and attempting to insert them. These are really extending beyond the experimental stage into clinical trials. And I think this is very important because if we can find ways to genetically treat sickle cell disease, we probably will be able to also treat other inherited disorders of red blood cell metabolism, other inherited problems with the hemoglobin molecule that we call thalassemias. So I think this is a very helpful and really a major breakthrough. And I think we're going to be hearing more about it. And I think eventually we might begin to talk about some definitive treatments, if not cures, for this condition, which has ravaged so many communities in which there are large populations at risk. So keep an eye out for new treatments for sickle cell anemia and other diseases of hemoglobin and the hemoglobin molecule. I'd like to turn now to a second innovation, which I think is really important, and that's to treat multiple sclerosis. Multiple sclerosis tends to affect a different patient population, often individuals of European heritage. It tends to be more common further away from the equator. Scientists have wondered whether this is due to genetic factors or environmental factors, but the disease tends to strike people between the ages of roughly 20 and 50 years. It's thought to be due to a combination of genetic and environmental factors. The end result is damage not directly to the nerves, but to the insulating sheath that surrounds the nerves. This results in destruction of the protective sheath. Often the first onset of this occurs in the optic nerve to the eye, but it can occur anywhere in the central nervous system. And the result can either be a single episode that resolves, a sort of steady state in which individuals have some damage that persists, or a relentless progressive path in which it slowly gets worse. And this is a very significant disease. It's touched my own family. My mother-in-law was stricken with this and was confined to a nursing home. Interestingly, she was from the Philippines, where it tends to be less common. So anyone can be affected by this. Currently, we're looking at phase 2 studies of a new drug, which is a monoclonal antibody that shows an effect on some B cells that are involved in the pathogenesis of multiple sclerosis. So the question becomes, are we dealing with a situation in which there is an autoimmune component to this? And if so, can we treat it in a manner analogous to the way in which we treat other autoimmune diseases in which the body's immune system attacks tissues? For example, rheumatoid arthritis. We have a lot of biologic agents to treat rheumatoid disease, to treat psoriasis, to treat psoriatic arthritis. And now we may be looking at adding treatments for multiple sclerosis. The phase 2 drug that's under study now is called ocrelizumab, and expect to hear more about that. The problem with treating conditions like multiple sclerosis is that even if we have a successful treatment, typically we don't reverse the damage that has already been done. Therefore, the goal eventually, I'm sure, will be to treat people early in the disease course and to prevent some of the end results of this devastating condition. Let's turn to something else that I think is really an upbeat and positive development, and that is smartphone connected pacemaker devices. These are pacemakers, but instead of being connected just to a battery and existing in isolation on the patient as the patient walks around, or on the person as the person walks around, these are connected via Bluetooth with the employment of mobile apps. And the results suggest that there may be a whole range of information that's part of a kind of smart medical approach to treating your heart rate, whether it's atrial fibrillation or other conditions. For example, you could be able to upload data and communicate this to your doctor. Your doctor could be able to track it in real time. And also there could be algorithms which would allow interventions to correct irregular heart rates. Now, we have defibrillators now that will fire when someone has a life-threatening irregular heart rate and can save lives. But this is basically taking that technology to a higher level that involves computer software and the possibility of more detailed study and understanding of individuals who have irregular heart rates, and the possibility of intervening to help them in a way that really was not possible before. And it's worth noting as we discuss this that February is Healthy Heart Month, and heart disease remains the number one cause of death in the United States. Interestingly, we've treated heart disease pretty well in terms of controlling cholesterol and high blood pressure compared to the success we used to have, although the percentage of people with high blood pressure who are really well controlled is lower than you might imagine. Nonetheless, we're making strides in that respect. Also, revascularizing the heart has made enormous strides in terms of bypass grafts and stents. So in some states, cancer is now the number one cause of death, not because cancer rates are increasing. In fact, cancer rates are decreasing, but because the success in treating heart problems has outstripped our success in treating cancer, leaving cancer as the #1 cause of death. There are 22 states in which cancer is the #1 cause of death, and California is one of those states. But positive developments are occurring both in the war against cancer and in the war against heart disease. Let's talk a little bit about cystic fibrosis. You may notice that we've talked about sickle cell anemia. We're talking about cystic fibrosis. We're talking about a number of conditions that seem to be inherited. And I think it's because there's kind of a revolution in medicine that involves understanding the human genome and realizing that many conditions relate to DNA. And that if we could correct that, we can make a big improvement in people's health. So 1 in 35 Americans carry the causative gene for cystic fibrosis. Tends to be more in populations of European extraction, but it can occur in different parts of the world. If 2 individuals each give the gene for cystic fibrosis to their offspring, the individual will be afflicted with a clinical disease, which really affects the production of mucus, the mucus that lines the airways. Also the mucus in, for example, the pancreatic secretions to the intestine. So individuals have a lot of problems, particularly with their lungs and with their digestive system. They may also have problems related to fertility and reproduction and other organs. Often bronchitis, pneumonia, and premature death can result. Now, with aggressive treatment with antibiotics and other interventions, individuals with cystic fibrosis are surviving longer than they ever did before. But a new development is the development of combination therapies, including transmembrane conduction regulators that are called CFTR related compounds. These regulate the chloride channel opening and diminish the production of thick mucus, improving clinical status. So the so-called CFTR modulators have the potential to really be a game changer with respect to treating cystic fibrosis. And I imagine eventually we will look at inserting genes and other interventions similar to what we discussed previously with respect to hemoglobin-related diseases. So again, these things take time to develop, to go through clinical trials, but I think the future is looking very bright long-term for more successful treatment of cystic fibrosis, which is a really devastating condition. I want to talk a little bit about hepatitis C. We used to call hepatitis C non-A, non-B hepatitis because we didn't know precisely how it was caused. We now know that it's generally something that people acquire via transfusions or via sharing products that are contaminated with blood, such as drug paraphernalia. And we call it now hepatitis C rather than non-A, non-B. It seems to have really hit the baby boomers hard, those born between about 1946 and 1964. And what we're finding is that a lot of people who really have not had risky behaviors in their recent years may have had some experimentation with drugs or some interaction with drugs when they were younger and may have contracted this virus. It can be sexually transmitted, but uncommonly. We didn't used to screen blood transfusions the way we do now, so that was another mechanism of transmission. So certainly people who have this do not uniformly have a history of drug use by any means. But the key thing is middle-aged individuals or older individuals may have this virus, and it's estimated that 3.2 million Americans are infected with hepatitis C. Why is that important? Because about 10 to 15 of people with this virus, 10 to 15% of people with this virus will develop complications, either cirrhosis of the liver, which is end-stage damage to the liver in which it becomes fibrotic and contracts, or hepatic cancer. And we know now that many liver cancers are related to hepatitis C. So there are now combination therapies. I listed one that's recently emerged in phase 3 trials. Sofosbuvir, velpatasvir. We used to also use other agents. There are other approved agents, but the key is that there is now a large choice of agents to treat hepatitis C. Each one has some side effects. We used to use interferon, which caused fever and malaise and a lot of problems. But looking at all of the available options for treatment, we can achieve a cure rate of hepatitis C between 95 and 99%. So what is the take-home message? I think the take-home message is that we need to test more. And in fact, 3/4 of people with hepatitis C are completely unaware that they are infected. If they can be tested and be found to either be non-infected or be treated if they are infected, we could prevent a lot of premature deaths. So this concept has been referred to by the Cleveland Clinic as universal hepatitis C treatment. And it really means employing modalities that we now have and employing them aggressively. You know, not all of medicine involves new scientific breakthroughs. A lot of medicine involves taking things that we know how to do and simply doing them, which is a logistical challenge that involves really education of physicians, education of the public, education of other healthcare providers, and trying to foster these positive relationships where we can really prevent or treat disease. I want to turn to a pediatric condition. Premature babies often have lung problems because they lack surfactant in the lungs and they need to be ventilated or provided with ventilatory assistance in order to survive. And in fact, premature babies are doing better than they ever did before with neonatal intensive care units. I have a couple relatives, my niece Emily, who's a neonatologist who's involved in treating heart disease in children, and my brother-in-law, Yao, who's at UCSF, who runs a neonatal ICU. And so I know that the new generation of doctors, some of whom are much younger than me, are gravitating towards treating these premature children. And one of the modalities is continuous positive airway pressure, abbreviated CPAP. Now, we've had that for a while, but some of the new CPAP devices are called bubble CPAP. And what they involve, among other things, is a very tight seal over the nose or mouth in order to avoid leakage of air. Positive airway pressure means at the end of inflating air into the lungs, there's pressure that expands the lungs. This is a new variation of that in which the pressure is more continuous. And the oxygen that is delivered to the lung is humidified with water vapor. What that does is it makes it easier on the lungs so that these premature lungs have an opportunity to develop and maintain oxygen flow to critical organs until the premature baby is able to graduate from the neonatal ICU and go to a regular unit and eventually go home with the baby's family, which is the goal that we all have, right? I want to talk too a little bit about telemedicine. Now, it's interesting because when we think of technologies changing, I used to always think that what really happens is that people adopt new technologies. That's true, they do. But another thing that happens is that there's a generational change. So, for example, older physicians who may not be comfortable with computers or telemedicine, they retire. Newer doctors who are younger come in and they embrace new technology. I should add, though, that some older individuals are really good with technology and embrace it with enthusiasm. I'm acquainted with some in their 80s and 90s who are technologically very sophisticated. But what's happened with this pandemic is that physicians of all ages have had to embrace new modalities to communicate with their clients or patients and other physicians. And so telemedicine has really exploded. In fact, the Cleveland Clinic has identified this as one of the 10 major breakthroughs for 2021. Seeing individuals from remote locations is a challenge, but nonetheless, 9 out of 10 physicians now employ telemedicine. This could be viewed as a kind of bright side of an otherwise sad situation with the pandemic. I've done telemedicine intermittently for 20 years. I used to do it when I worked for the Department of Corrections. And there were remote prisons in which I was asked to assess people as a rheumatologist for arthritis. The challenge is that you can't do the physical examination the way you would like to do that. You have to rely on looking through the monitor and so forth. But I think that's changing also. My son Luke is hoping to become a chest surgeon, a cardiothoracic surgeon, and he spends time with a surgeon who's at John Muir Medical Center following him around to learn about heart surgery and chest surgery. And a lot of it is done now remotely with robots, Da Vinci robots specifically. And these are robots that use small devices so that, for example, surgery that used to require a huge incision in the chest that was this big now require little small incisions. And I think the military also is exploring the use of robotic technology. So eventually what I see happening is that telemedicine will combine with robotics to allow physicians to perform procedures from a distance. And I think that's already beginning to happen. Because in the case of the cardiothoracic surgeon I described, in fact, the surgeon may be seated across the room from the patient who's being operated upon and may be accessing the surgical tools through computer software and hardware. So telehealth is really exploding, and it may also lead to some benefits for patients because patients will not have to drive through traffic to see their physicians. I do want to say, though, that we need a cautionary note here because I do think the face-to-face interaction between doctor and patient is something that's existed in medicine since the time of Avicenna in Persia, the time of Hippocrates in ancient Greece. And I don't think we want to turn our back on that completely. It would be a sad thing if we did, in my estimation. There are also issues related to liability that are being sorted out. You know, if you talk to somebody over a telemedicine hookup and you miss a diagnosis, to what extent are you liable for that? I know that my own malpractice insurance company has sent me letters explaining the need to be cautious in this respect. So we're going to have to see how much society adopts this technology, how willing people are to go along with it, and also what technological advances occur and what the liability implications are. But I think eventually this will be added to our armamentarium more and more. And doctors who do not embrace telemedicine, they may be unfortunately left behind. I want to talk about third world countries. Childbirth is a really vulnerable time for not just the infant, as we discussed, but for the mother. And many mothers die in third world countries during childbirth. Fortunately, this is something that has become quite uncommon in the United States in hospitals. When death does occur, it's usually due to hemorrhage. On occasion, historically, it could also be due to sepsis or widespread infection. In fact, one of the big advances in obstetrics was aseptic technique, and then delivering babies in a manner in which there was access to intravenous fluids and transfusion, as well as surgical intervention to stop bleeding, in the extreme case, including C-section or even hysterectomy if it's a disastrous situation. But in third world countries, if a mother upon giving birth starts to hemorrhage, she could bleed to death in a matter of less than an hour. This afflicts 5% of women giving birth, and it's a common cause of death in less developed countries. So the new technology is vacuum-induced uterine tamponade. This is a device that essentially creates pressure in the uterus through the use of a vacuum device that's minimally invasive, that tamponades or shuts down on bleeding. I have to admit, frankly, that I don't know that much about it. I wonder why it's based on vacuum rather than pressure. But the technology, I think, involves creating a vacuum and then altering the pressure in the uterus in such a way as to put pressure on vessels. And because it's minimally invasive, it might be available to individuals who do not have a lot of technology available to them, doctors, nurse practitioners, and others in third world countries, I guess midwives as well, nurses. So that's important also because it reminds us that when we talk about a comprehensive approach to human health, we have to remember that not everyone has access to the University of California, Davis, or the Mayo Clinic, or the Cleveland Clinic. I want to talk about prostate cancer. It's the second leading cause of cancer death among American men. I believe lung cancer is still number one, but lung cancer is declining as smoking rates decline. Prostate cancer tends to be a chronic condition. Actually, a majority of people with prostate cancer die with it rather than of it. What does that mean? That means that they may have this condition for 10 years, and they're usually elderly and they may die of some other cancer or heart disease or something else. We know from studies that have been done of tissue from prostate glands that elderly men, say over the age of 80, tend to have prostate cancer at least located in the gland most of the time, meaning that perhaps 70% of older men, if you look carefully, will have some prostate cancer. That's interesting because we tend to think of cancer as always being disastrous, but prostate cancer has taught us that you can live with cancer as a chronic condition. In fact, we're now finding that the same may be true of some forms of breast cancer, ductal carcinoma in situ, and some have even suggested that it might be treated in a way similar to the way in which we treat prostate cancer by watchful waiting. But there are new breakthroughs for prostate cancer. Traditionally, we've used surgery, radiation, and chemotherapy after staging the cancer. The new advance is ADP ribose polymerase, which is abbreviated as PARP, P-A-R-P, all capital letters. It's an enzyme, and it seems to represent targeted therapy that slows down the reproductive rate of tumors and thus seems to really prevent prostate cancer from advancing as quickly as it otherwise would. It's felt to be a major breakthrough, and we'll have to see how it's targeted, how it's tolerated, but it's considered targeted cancer therapy. And I think, again, for prostate cancer, with so many people afflicted by it, so many men affected by it, there's going to be a great impetus for further research. Immunologic therapies for migraine headaches are now emerging. Migraine headaches affect 40 million Americans and contribute to work absenteeism and a lot of generalized misery. In fact, migraines can even be associated with stroke in some cases. It's interesting too, because I recently saw a case of a gentleman who kept coming in with a migraine headache, had an MRI performed, and was found to have an ependymoma, which is a brain tumor, fortunately with a better prognosis than most brain tumors. But evaluating migraine often involves evaluating and ruling out other conditions, and we're always concerned about more serious conditions such as a brain tumor. But there is a new treatment for migraine that is emerging. It's calcitonin gene-related peptide blockade using monoclonal antibodies. Early studies suggest that this has a 50% efficacy in treating migraine. One of the things we want to do with migraine, if possible, is find treatments that do not involve narcotic analgesics, because as we all know, we have seen really an epidemic of deaths associated with opioids, and often prescription of narcotics can lead to a cycle in which an individual may become dependent if careful oversight is not employed. It doesn't occur in the vast majority of people, but obviously we're seeing that the pendulum seemed to swing too far towards prescribing narcotics. And this is something that has tragically affected many families and many communities. And we've seen this in our own community. I know that we've seen it in our own circle of friends, among our family, and in our own community. And so any non-opioid treatment for migraine is something that we welcome. I indicated that I would cover the 10 major breakthroughs for 2021 that the Mayo Clinic, sorry, I said Mayo Clinic, but I meant to say Cleveland Clinic, recently published online. These were all from the Cleveland Clinic. I want to acknowledge the Cleveland Clinic, which is a leader in my own field of rheumatology in many sub areas of rheumatology, including treating inflammation of blood vessels and other conditions. Also, they're major leaders in heart surgery and many other fields. So I want to acknowledge the Cleveland Clinic. And for that matter, the Mayo Clinic is also excellent, but I'm talking about Cleveland Clinic here with respect to these 10 breakthroughs. I'd like to, though, mention a little bit about COVID-19 before we open it up for questions. And I'd like to say that, it's been a long haul for all of us. I think this virus has been a terrible thing in many respects, because not only does it cause death, but it also causes social isolation and economic disruption. And I'm very hopeful that with the advent of the vaccines that we now have, we're going to begin to see light at the end of the tunnel. However, social distancing, the use of masks, and hand washing remain cornerstones of prevention of this. One thing that I think is very interesting that doesn't get a lot of press that I'd like to share with you is that this has been a very mild flu season. The number of cases of influenza that we're seeing has been much less than one normally sees in hospitals. Why is that? Well, probably because everything we do to prevent COVID-19 also prevents the flu. Now, human contact, human touch, talking to people is also an important part of who we are. Obviously, it's not realistic to think that we're going to maintain 6 feet of distance between us for the foreseeable future or forever. But maybe for the next few months while we get through this, maybe longer, this might be the reality that we have to deal with. And certainly, if you can maintain 6 feet of distance between you and other people, use masks, wash your hands, and avoid contact with people who might infect you, particularly if you're at risk, if you have chronic health problems like heart disease, lung disease, or if you're elderly. Avoiding these contacts is helpful. We don't know exactly how this virus is spread in every circumstance, but it seems that social events often do play a role. To be sure, there's an element of speculation there, but we don't want to lower our guard. Recently, I was on the inpatient service at UC Davis consulting for rheumatology, and the fellow I was working with told me that we had 88 patients on the dedicated ward for COVID, which is a pretty large number. I was fortunate enough to be offered the vaccine because I was classified as tier 1 because I had face-to-face contact with so many patients. I know that others are struggling to get this vaccine. By the way, there's several different vaccines available. The one I got was from Moderna. Obviously, Pfizer has one. Johnson & Johnson, I think, recently just got approved. AstraZeneca has one. The Russians have one that they call Sputnik, and there's one from China as well, but I don't know too much about them. I do know that among those that have been approved by the FDA in the United States, they look pretty promising, and the data are good. The Moderna and the Pfizer one are both messenger RNA vaccines. That's a new technology. Essentially, the messenger RNA stimulates the body's muscle cells to produce the spike protein on the surface of the COVID virus, or at least to produce molecules similar to that. That in turn stimulates an immunologic response that protects us against the virus. There are logistical hurdles that remain for distribution. The Pfizer vaccine in particular has to be refrigerated at an extremely cold temperature. The Moderna vaccine, not quite as cold a temperature. I believe the Johnson & Johnson vaccine has as one of its selling points that I believe it's a single injection, whereas Moderna and Pfizer both require follow-up injections. In the last few days, I could say hot off the press, we've seen a lot of discussion of new viral strains from Britain, Brazil, and possibly even California that seem to spread more quickly and have mutations relative to what we prepared these vaccines for. We'll have to see how that unfolds. It appears that the mutations affect the degree of contagiousness of the virus more than they affect the actual clinical presentation of the illness. I have to say I'm a little disappointed with the speed of the rollout. I could find areas to criticize, but I do think that you should talk to your own physician about what's best for you. I know some people have expressed concern about side effects of the immunization, but and if you're profoundly immunocompromised from cancer treatment or other conditions, there are contraindications to getting vaccinated for COVID-19 for some people. But I would say for the vast majority of us, it makes so much sense because the benefits outweigh the costs. And so I'd like to end on a positive note, and also hoping that we get more people vaccinated so that we achieve a critical level where we have what's called herd immunity and where the virus doesn't spread so easily through communities. And I'd like to thank Kathy Rich in closing for the fantastic job she's done in helping me to work with a great team at public access television in Davis and in Vallejo, and making Health Focus a show that really, I think, has a little bit of a local influence, at least on people, and has resulted in some positive feedback. Our slogan is to say, remember, at Health Focus, we focus on your health.